Hi, welcome. My name is Arnab Datta, MD, and I'm a psychiatrist. My practice is called Tresna Mental Health, and I'm the medical director of an amazing clinic in Staten Island and New York. It's called Revcore and Silverlake, and I'm going to be presenting today with Dana Davino.
Hi, I'm Dana Davino. I'm the clinical director of Silverlake Behavioral Health, licensed mental health counselor, and soon to be clinical psychologist.
This is episode number 1 of our podcast. So today we want to show you how we talk about a client, how we talk about a patient. We're going to be presenting the case of Emily, and Dana's going to be reciting this case about Emily. So it gives you some inside information how psychologists, how psychiatrists are thinking about a client or a patient. And then we're going to be talking about certain psychological concepts that's going to help Emily. And we're going to talk about some medical psychiatric treatments as well. Okay, so Dana is going to run us through this case.
Sounds good. Let's start. So let's go. Emily is a 28-year-old woman who has been brought to treatment by her family following a suicide attempt after her fiance broke up with her. In particular, Emily's family expressed concerns about her escalating substance use disorder, primarily involving alcohol and prescription painkillers. Emily's substance use has led to significant disruptions in her daily life, including job loss, strained relationships, and legal issues. Emily presents as resistant to treatment, expressing anger and frustration at her family's intervention. It's important to note that this is Emily's third suicide attempt. Her first attempt was at age 16. She was hospitalized for 2 to 3 days following her first heartbreak. Her second suicide attempt was at age 21 after a torn ACL. She was prescribed oxycodone and overdosed on her prescription. Some background information about Emily. Emily grew up in a middle-class household as the youngest of 3 children. Her father was a high-functioning alcoholic, and her mother was often emotionally unavailable, struggling with depression. Emily recalls feeling neglected and seeking attention through rebellious behavior during her adolescence. She started drinking in high school. In high school, Emily found her strength in soccer. Emily was doing well as a soccer player in high school, so much so that she played college, and this was a major part of her identity. Going to soccer practice was good for her. Her soccer coach was a positive figure in her life. She was thriving. She was an A to B student. This was her saving grace. Emily's injury not only caused physical pain, but it caused her to feel disconnected from her coach and from her team. That's why it was so tough for Emily when she tore her ACL. As a result of feeling desperate, Emily began misusing prescription painkillers, overdosed, and dropped out of college. Emily started therapy and she started to feel better as she was in a relationship, and eventually she got engaged. She selects a fiance that was very similar to her father. He was well-to-do, and she finds stability in him, but he also drank. As she was searching through his phone one day while he was sleeping, she saw a text from one of his previous partners. It didn't matter that the text was purely informational and was only advising him that a mutual friend had passed away. This started a fight. But this wasn't the first time. They would fight like this often. However, this time, her fiancé was so frustrated with her constant accusations that he broke up with her. She believed her fiancé was genuinely in love with her and knew that he was not cheating on her, yet she couldn't explain her reaction, and she reported she was not able to control herself. She didn't know she does know that her behavior is what caused the breakup. In addition to her substance use disorder, Emily has been diagnosed with major depressive disorder. She reports persistent feelings of sadness, hopelessness, and worthlessness, which she believes contribute to her substance use as a form of self-medication. Emily has a history of self-harm, and this is her third suicide attempt. So that is the case of Emily.
All right, so what we've just recited is a case of a patient. And the way we approach treating patients is both from a point of view of psychiatry and psychology. You know, one of the triads I'd like to mention is, in this case, we're going to be talking about the triad of trauma, borderline personality traits or other types of personality disorder traits, and substance abuse. Okay, sometimes patients are hospitalized and they get the diagnosis of schizophrenia. They get the diagnosis of bipolar disorder within the hospital. However, when they come to the outpatient clinic, we see that schizophrenia or bipolar disorder is not their diagnosis. Rather, it's a triad in this really unique constellation of trauma history, personality disorder traits, and substance abuse. So in this case, we're going to talk more about that.
All right. So when we look at the case of Emily, we see a lot of things going on. Part of her trauma, when we look at her relationship with her mother, is this early insecure attachment, right? So her mother was physically present, but unavailable. So there's this constant insecurity of the mother's attention and support. So Emily has this insecure attachment, right? So that increases her questioning, her suspiciousness in the relationship with her fiance.
That's right. So one of the things that happens when someone experiences trauma is, say, the father was a bit narcissistic and the father consumed alcohol, and the father wasn't able to be that empathic towards Emily. And say the mother was a little bit depressed and she couldn't really stand up for Emily. You know, Emily's needs were not, emotional needs were not really met. The mom could not defend her against Emily because the mom was suffering from her own overwhelm, her own depression. So what sometimes happens is love in Emily gets registered in the wrong category. Instead of love being registered as safety, love is trust or consistency. What love is, it kind of registers within Emily as abandonment or fear that she's not going to be loved. And that manifests as some things that we're going to talk about. Sometimes love gets in the category of emotional chaos or emotional pain, you know, which results in instability. You know, people can start thinking that love requires suffering, or I need to prove my worth in an overwhelming fashion, or love gets registered in over idealization. You know, I need to find the perfect love to fill a certain void that I feel, or even hypervigilance. Love gets registered as that, like, oh my God, I'm really anxious, you know, and I need to test my love because I'm fearful of betrayal. So we're going to talk about how Emily experiences these things, and we're also going to have future episodes where we're going to psychologically go into different areas. So we're going to discover, you know, for example, different psychodynamic, different unconscious elements of what's going on here. So stay tuned for future episodes. But this is how we talk about patients, and this is the level of skill that we bring to the table when, as we get to know our patients, as we're treating our patients.
And one thing I just want to mention about early relationships, early childhood relationships pretty much set the script for what those dynamics will look like later in life. And it's not because we seek out exactly that, it's what we seek out what is familiar, not necessarily what is comfortable. So although Emily is chasing, right, in her script, chasing somebody who's not emotionally available, that's what love looks like. So when she finds herself in situations later, it's not because it's comfortable for her. It's because that's what's familiar for her.
Yes. In the realm of unconscious conflicts, for example, because Emily didn't get the proper attention from her father, the proper empathic need from her father, she's going to have a fear of abandonment. Emily might be clingy. She might be possessive. She might have a desperate need for reassurance. Like in our case presentation, when her fiance broke up with her, it reinforced these fears within Emily. It triggered fears of, oh my God, I'm worthless, and despair, which led to her third suicide attempt.
So as we look at Emily, Emily uses some defense mechanisms, right? One of the defense mechanisms is denial. Typically, the first one that people use is denial. And she plays down the severity of her substance use and its impact. Okay? Another one is rationalization. With rationalization, we can justify, or Emily justifies her alcohol use, that her painkillers were necessary for to manage her physical pain, even though she was using them also for her emotional pain. What else do we see there?
And another defense mechanism is projection. You know, Emily might blame her family for her problems when she needs to take responsibility. And we're going to talk about how we provide treatment to Emily, but part of the treatment is helping the client or the patient take responsibility, have accountability for their own feelings, what they're feeling, you know? So we'll see that Emily, she's deflecting responsibility from herself. She's going to use painkillers or drink alcohol, and she's going to blame other people for it. Sure, it emanates from the emotional thing that she didn't receive in childhood, but this is something that Emily has to become stronger within herself.
Yeah. And a key point that I just want to bring up, and maybe we can discuss a little, is how Emily knew that she was overreacting. In that last fight with her fiance, she knew that she was overreacting, and it was almost as if she couldn't control herself. She couldn't stop herself from having this reaction. And one of the characteristics in Emily's case is this inability to self-regulate, right? So we see the substance use as an external form of self-regulation. So when we conceptualize Emily, we're looking at this part of her personality that has this intense emotion that is unstable or unstable.
One thing I wanted to mention is Emily is showing signs of borderline personality disorder, okay? So Emily's repeated suicide attempts, it reflects this internal chaos that she has, this feeling of despair that she has inside herself, which is associated with unresolved trauma, okay? And the substance use, and this is really hard for her to deal with, to process, to understand. So in order to escape that, she uses painkillers. She uses, you know, oxycodone or alcohol. So this is something that's improved in therapy. You know, other symptoms of borderline PD, because Emily feels emotionally abandoned, she has this reinforcing belief that her relationships might be unsafe, that her relationships might be unreliable. There's also another thing that borderline patients do, they split. That means they see people as all good or all bad, okay? And so Emily, she has some unstable interpersonal relationships because she's alternating between these extremes of idealization and devaluation. Sometimes patients like Emily or clients like Emily, they might have inappropriate outbursts of intense anger. They can lose their temper. They can have recurrent physical fights. They might have an identity disturbance because they have an unstable sense of self, which comes from this inconsistent or neglectful caregiving during childhood. So self-harm is a way to cope with overwhelming emotions, particularly those tied to this perception of rejection and abandonment, which really did happen when Emily was a child, because her father would drink and not really be there for her empathically, and the mom couldn't really stand up to him and couldn't really fortify or support Emily emotionally. So clients like Emily, they might have, we call it affective instability or reactivity in mood. In the psychological world, affective means expression. It could be facial expression, it could be eye contact, it could be also, they may not be level-headed all the time. They may get very, very reactive. And folks like Emily might have chronic feelings of emptiness. So when people have about five of these criteria, over a prolonged period of time, they might be diagnosed with a personality disorder or a borderline PD in this case.
One thing I'd like to mention when we talk about self-harm, self-harm does not always just refer to self-injurious behavior. When we're looking at self-harm, we're talking about substance use, gambling, even intent shopping, where it's at a detriment to you financially. What else? What are you thinking?
Those are some good topics. Yeah, this impulsivity, it could be substance abuse, sex, reckless driving, binge eating, overspending.
Yeah.
You know, when we approach treating someone like Emily, we are trying to treat the psychology and the emotions behind it. This craft of mental health treatment, the psychiatrist myself, the psychologist, Dana, we come together in a clinic like Revcore and Silverlake, Tresna, and we try to improve the emotional and the psychological strength. And we try to make the patient that strong from the inside that they may not need medications, but some people do. Our treatment is not a one-size-fits-all. It's very, very customized. And even though we will prescribe medication to somebody like Emily, that will make the psychotherapy experience easy for her. That will allow her to achieve these milestones in psychotherapy, perhaps in a more efficient way. And the goal is to eventually be off the medications.
So from a psychotherapy standpoint, one of the strong models that are used for anyone with borderline personality disorder is something called dialectical behavioral therapy. So also known as DBT. DBT has 4 components that are that will prepare and strengthen Emily. One is mindfulness, right? It's to be grounded in the moment. Because again, Emily gets lost in anxiety, she gets lost in her reaction. So mindfulness would strengthen her ability to be grounded. Another part is distress tolerance, right? Distress tolerance is her ability to cope, to her ability to handle things, right? So that is another part that's worked on through DBT. Emotional regulation is definitely another one. And then individuals with borderline personality also have interpersonal issues, so interpersonal effectiveness and social skills. So those are the 4 main components when we're working with DBT.
Amazing. Yeah, DBT is a great psychotherapy. It was created by Marsha Linehan. Sometimes there's an amazing manual, a DBT manual that's used. You might have heard about it. If you have seen a psychiatrist or therapist in the past. Another type of therapy that's really great is called psychodynamic psychotherapy. That's where the unconscious mind is explored. So this is one of the nuances of seeing a psychologist or a psychiatrist who is well-versed in psychotherapy. Essentially, it's like the psychologist should have an objective point of view. The psychologist should see you without bias. They should hear your story without bringing their own biases or traumas into it. You know, so a lot of psychotherapists and psychiatrists, they've gone to their own therapy, which is a very healthy thing for anyone to do, really. We all need someone to listen to how we're feeling. So the unconscious mind is explored in psychodynamic psychotherapy. And with Emily, that's where she can learn to identify and process some of these unconscious conflicts that she has that's related to her self-worth and emotional pain. This includes exploring the roots of her depression and substance use as well. And another great type of therapy is CBT. Dana, do you want to talk about that?
So CBT is cognitive behavioral therapy. It is how the thoughts affect the behavior. And when we can look at that triad, we can figure a point, or we help build a point in where instead of having an automatic thought and a reaction, it may be that automatic thought, but there's a point where you can actually check yourself about that. So if you're having a negative thought, you don't automatically react to it. It's negative thought, kind of, okay, let me evaluate that. And then not necessarily have the behavior that you originally were going to, right? So when we are changing behavior, CBT is one of the models.
Now let me mention about some of the medications. We want to increase the emotional strength, the psychological strength of the patient, but medications can be a really helpful tool to make that process more efficient. In personality disorder traits, one medicine that's really good is a mood stabilizer called Lamictal. So Lamictal, what it does, it inhibits voltage-gated sodium channels in the nervous system to reduce neuronal firing. So what this does is it reduces irritability. It reduces mood instability. It reduces impulsivity. Okay? For example, Emily is hurting herself because she's having feelings of abandonment that emanate from the traumas of her childhood and the neglect in her childhood. Lamictal is going to even her out. It's not going to make her feel numb. It's going to be able to have Emily be less impulsive and less self-injurious so that she could sit through the psychotherapy. And one of our future podcasts is going to talk about transference versus countertransference, what the therapist feels about the patient and what the patient feels about the therapist. And Lamictal actually makes for a more harmonious patient-doctor relationship or patient-therapist relationship. And what we're going to see is what happens in that therapeutic space between patient and doctor. Well, it's sort of a mirror or a reflection what happens in Emily's life with her mom, with her dad, with her fiance, with her peers. Okay. Another medication is naltrexone. Because Emily drinks alcohol, because she uses painkillers from time to time, naltrexone is an opiate receptor blocker. What it does is it helps you use less drugs. Naltrexone is also good for behavioral addictions too. It helps people reduce gambling addiction, internet addiction, sex addiction, things like that. It is reducing the craving for drugs or certain habit-forming compulsive behaviors. And it's been amazing tandem when used with psychotherapy.
Yeah. So I think one of the important things when we discuss treatment is, as psychologists, as psychiatrists, we are not going to tell people what they have to do, right? So people come with their own goals, and it's really important that those are developed collaboratively, right? Because if I tell somebody what to do, I'm going to get more resistance than I'm going to get cooperation, right? However, if somebody comes in with their own goals, we can help them work towards achieving them, which is definitely different than some other places or some other models, right? So whether it's harm reduction or abstinence, when people come in, the first thing we do is just listen, because they're here for them, right? And we're here to help.
Yeah, our treatment is this interplay, a teamwork between patient or client, the therapist, the doctor, the psychiatrist. It's an interplay with this team. Okay, we do like it when the patient brings, a plan. However, we're here to do this teamwork. We're here to suggest best practices, and how we could achieve these goals. So, in this case, this is how we discuss a patient situation, a patient's case. And, Emily's case highlighted this interplay, this intricate interplay between substance use, mental health issues, which were influenced by early attachment and unconscious conflicts. And it shows the comprehensive care that we provide at Silverlake Behavioral Health, Revcore, as well as at Tresna. So stay tuned for our future episodes, and we'll go more in depth into these mental health concepts.
Take care.